Today we will see about the obturation. Obturation is a method used to fill and seal the cleaned and shaped root canal using a root canal sealer and core filling material. If you see, what are the requirements for an ideal root canal filling is that the material should be easily introduced into the canal and it should seal the canal laterally as well as apically. And it should not shrink after being inserted, and it should set slowly. And it should be impervious to the moisture, and it should be bactericidal, or at least it should not discourage the it should at least discourage the growth of the bacteria. That is, it should be radio-opaque and does not stain the tooth structure or neither irritate the periradicular tissues. So we'll see when to obturate the root canal. See, the clinical criteria for timing of obturation is that the canal should be reasonably dry with no weeping of canals in the form of bleeding or discharge of serous fluids. And optimal shaping and cleaning of the canal can be easily achieved in a tooth with a vital pulp tissue. And further, the pre-existing radiolucency are more common. So, in such cases, there is few protocols before deciding the time of obturation. Now we will see what are the obturating materials are. According to the history, the silver cones were used to fill the root canals. But they are stiffer than the other material when they are inserted into the canals, and they cannot get into the fine and tortuous canals. So, they are no longer recommended in endodontic practice. So, currently used solid filling materials are the gutta-percha. The gutta-percha was introduced by the Bowman, and it is the most popular core material. Here it consists of 20% gutta-percha matrix and 66% of the zinc oxide and 11% of the heavy materials and the 3% of the wax or resins. If you see, it is a rigid natural latex product from the sap of the rubber tree of genus Palacium gutta. And it has two phases. The alpha phase gutta-percha is more commonly employed in thermoplasticized gut techniques, while the beta phase gutta-percha is more popular in the lateral condensation technique. So, they have standardized the gutta-percha cones as according to their sizes, which are used clinically. Now we'll see about the Resilion. The Resilion is having the high performance because of the polyurethane content into it. This system can be used by the lateral compaction and the warm vertical compaction or the thermoplastic injection. And this Resilion requires 150 degrees temperature for thermoplasticized technique, which is less when compared to the 200 degrees temperature required by the normal gutta-percha. And if you see, this has been recommended in the long-term clinical trials. Now we'll see about the MTA, that is mineral trioxide aggregate, which can be used for the canal obturation material because of its superior physiochemical and the bioactive properties. So, MTA obturation can be combined with the root end resection and with the open apices, and with the retreatment with MTA obturation, internal resorption and transcendentic cases. And it is the most biocompatible material when compared to the all other materials. Now we will see the techniques of the obturation. In that we have the collateral compaction, warm compaction, vertical and the lateral, and the continuous wave compaction technique, and the thermoplasticized gutta-percha injection, carrier-based gutta-percha, that is thermoplasticized, simply fill sectional obturation, and the mixed pad and thermomechanical compaction, chemically plasticized gutta-percha, and the custom cone. In that, we'll see the first one, that is a collateral compaction. This has been one of the most commonly practiced obturation techniques And this is the in the contemporary endodontics, it is the best to achieve the three-dimensional shape. In that, clinically we consider the three consideration. One is the sealer consideration. That is, the sealer application on the canal walls can also be performed using the lentrospiral or with the master gutta-percha cone itself. Next is the spreader considerations. The size of the spreader is determined by the width of the prepared canal and the lateral fit of the primary cone. The spreader size should reach within 1 to 2 mm of the working length in order to obtain the optimal apical compaction. And the master cone considerations is that the selection of the master cone should be similar to the master apical file size. Additionally, secondary cones are inserted until the spreader cannot be reinserted. That is an indication that the root canal is fully compacted laterally. Now we'll see how this technique is done. First and foremost, isolate and the drying of the canal with the paper points is done. And the selection of the master cone is done, then checking for the apical tuck back is done. Here, the radiographic verification of the master cone fit has been done. If it is at the working length, the sealer manipulation and coat the canal with the sealer using the master cone or with the lentulospiral, and the master cone is inserted till the working length and a hand or figure spreader, and it is inserted along the master cone to the level of 1 mm short of the working length. And the spreader is disengaged from the cone by rotating it between the fingertips or by rotating the handle in the arc. And the placement of the sequential axillary cones by the lateral compaction until the complete obturation of the radicular space is been done. Then the post-obturation radiograph is been taken. If suppose it is beyond the apex, what we will do? We will cut off the excess from the tip and reinsert it and then verify with the radiograph. If at all it is short of apex, what we'll do? We again find the patency to establish the correct length, followed by the sequential irrigation, shaping and cleaning of the canal, and another primary gutta-percha cone is fitted to the correct working length for the radiographic verification. But this technique has some limitations. Is that the presence of voids between the canal, and there would be an increased sealer and gutta-percha ratio when compared to the thermoplasticized gutta-percha. Now we'll see about the warm compaction method. Here principle is that the warm vertical condensation of the filling root canals was introduced by the Schilder with an objective that the filling the main root canals as well as the lateral and axillary canals using the heated pluggers. The Schilder's objective is that there should be the continuous tapering funnel should be present from the root canal orifice to the root apex, and the root canal should be prepared so that it flows with the shape of the original canal, and the shape of the apical foramen should not be changed or moved, and the apical foramen should be kept as small as it is practically possible so that the excess gutta-percha will not be forced through it during the vertical compaction. So coming to the steps in that, here the master cone adaptation in the prepared canal is done, and there would be severing of the coronal portion of the master cone with a heater instrument, and then the compaction of the master cone is done with the sequential segments removed with the heat carrier, followed by the compaction. After that, once the apical third is reached, the canal is backfilled with the heated segments of the gutta-percha, followed by the compaction with the suitable pluggers. That's how the warm vertical compaction is done. Now we'll see about the continuous wave compaction technique. Here, this is a variation of the warm vertical compaction introduced by the Buckner, and this technique employs the use of gutta-percha cones and the pluggers that mimic the tapered preparation, thereby permitting the application of the hydraulic force during the warm compaction. If you see the clinical technique, Here, after selecting the appropriate master cone, the plugger is fitted to fit within the 5 to 7 mm of the working length, and the system B unit is set to 200 degrees and heated plugger, and it is moved rapidly to within 3 mm of the binding point. The heat is inactivated while the firm pressure is maintained on the plugger for 5 to 10 seconds. After the gutta percha mass has cooled, a 1 second application of the heat separates the plugger from the gutta percha, and then it is removed. Then the remaining canal is obturated using the thermoplastic injection technique such as the Obtura 3. That's how the satisfactory obturation is seen when compared to the cold lateral compaction. Now we'll see about the other techniques such as the carrier-based gutta percha. Now we'll see about the thermoplasticized technique. In this technique, it is a carrier-based gutta percha obturation system comprising a plastic core carrier coated with the alpha phase gutta percha. These obturation systems are used in conjunction with a heating device known as thermoprep plus oven. So, after the preparation of the canal with the suitable instruments, the size of the canal is assessed with the thermofill verifier instrument, which helps in selection of the appropriate sized obturator. The canals are dried and a light coat of sealant is applied. The silicone stopper on the carrier is adjusted to the working length and the carrier is loaded into the thermoprep plus oven for approximately 10 seconds. The carrier is then inserted into the canal and placed up to the working length with a firm, uniform apical pressure without rotating. The position of the carrier is verified radiographically and the gutta percha is allowed to cool for 2 to 4 minutes before resecting the carrier at the level of the orifice. That's how the thermoplasticized technique is used. Now we'll see the simply filled sectional obturation. It is a carrier-based sectional gutta percha obturation system used in conjunction with a light-speed rotary instrument. The simply filled carrier has an apical 5 mm plug of gutta percha which helps to perform the cold obturation of the root canal. Here, the carrier size is chosen according to the diameter of the master apical file. After drying the canal and applying the sealant, the carrier is introduced up to the working length. The handle of the carrier is rotated quickly in a counterclockwise direction 3 to 4 times to disengage the apical plug of the gutta percha from the carrier. So, the remaining coronal space can be filled with the lateral compaction or thermoplasticized gutta percha methods. Now we'll see the Mex-Padden thermomechanical compaction method. And this instrument or this method uses the heat to decrease the gutta percha viscosity and increase its plasticity. The heat is created by rotating a compacting instrument in a slow speed contra-angle handpiece along a gutta percha cone inside the root canal. The compactor whose spiraled 90 degrees flutes are similar to the flutes on the headstrong file, but in reverse the forces the softened gutta percha apically and laterally. So, as the compactor blade breaks easily if it binds, this method should be used to fill the straight canals only. So, that's how this method is useful. Now we'll see about the chemically plasticized gutta percha. Here, the gutta percha can be plasticized by chemical solvents such as the chloroform, eucalyptol, and xylitol. The disadvantage of using the chemical solvent filling material is its inability to control the overfilling. With the resultant periapical tissue reaction, the shrinkage of the filling after setting and resulting in a poor apical and the lateral seal. But this technique is no longer recommended. Now we'll see the custom cone technique. It is a chairside procedure employed for customizing the gutta percha in a wide canals, where the traditional master cone cannot be adapted. The clinician has to customize the gutta percha point to achieve the tuck back. That's how the custom cone technique is used. Now we'll see the root canal sealers. The root canal sealers are used in conjunction with the biologically acceptable semi-solid or solid obturating materials to establish an adequate seal of the root canal. In that, if you see, the Grossman's criteria for an ideal root canal sealer is that it should provide an excellent seal when set and provide an adequate adhesion between itself. It should be radio-opaque and non-staining and dimensionally stable, should be mixed and introduced into the canal, and it should be able to removed if necessary also. If you see, there are various types of sealers such as the zinc oxide regional base sealer. In that we can see the Grossman's formula, roots 801 and 2-glycol. Whereas the calcium hydroxide based sealers are Seal Apex, Apexit, the GIC based sealers and the resin based sealers. In that AH plus, AH26, Epiphany and Diacat are same. And in recent we can see the bioceramic sealers such as MTA and the biodentate. So in this, if you see, the root canal obturation can be easily done with an zinc oxide eugenol sealer when compared to the others, and the resin based sealers are more potent when compared to the other sealers. So completion of the endodontic therapy in a single visit is the new concept. So literature reviews that the single sittings are also can be traced almost 100 years back, and it gained popularity in recent years. And it has great acceptance as a treatment of choice for the most of the endodontic cases. So this is brief about the obturation of the root canal system.